Okay, everybody, welcome back. We're going to get into respiratory medical emergencies. This is a monster lecture. This is a monster subject matter. You guys are going to be tested on this throughout the course. You guys are going to be tested on this on your national registry exam. This is about 33% of your national registry exam that you guys will see, and a lot of this is going to be on your final. This is our cup of tea. We do very well in respiratory emergencies, and this is the first lecture into our big three. Into our big three systems, which is respiratory and cardiac and neuro. I'm going to break these lectures down again as best as I can into 20 or 30 minute segments so that you guys can review this and review the materials, the specific material that you guys want to review to help you guys with your studies. This is also a chapter that I recommend you guys read and you guys take notes as you guys are reading as well. So we'll get started here in one sec. Okay, so we're going to start with a real quick review of the actual respiratory system anatomy. Remember, you have your nasal cavity, which you guys can see on this slide here. Those little folds are called turbinates. Those turbinates actually act as a vortex for the air to kind of start to spin in our system so that the air only goes down our trachea instead of into our esophagus. All right. In the nasal cavity, we also have these hair-like structures known as cilia, and they help to actually filter the air that we breathe in. That air gets filtered. All that dust and pollen and other irritants is what makes our snot, or what makes our boogers, however you guys want to put it. From there, it goes into the main pharynx, which is your oral pharynx. Okay, remember that we have the tongue, which is the number one occluder of airways, specifically in our unconscious patients, and the epiglottis, which actually is connected to something called the hyoid bone. The hyoid bone connects it's the anchor for the tongue, and it connects the epiglottis to the actual anatomy structures itself. When you guys swallow, your tongue technically moves forward a little bit and it drops the epiglottis over the trachea so that the bolus of food that you just ate has nowhere else to go but down the esophagus. And then we have going down into the larynx. That's where the epiglottis is located. It's that little flap that you kind of see there in the picture. The larynx contains the vocal cords. Remember that the vocal cords is what separates the upper from the lower airway, which then enters down into the trachea, which is also known as your windpipe. That's anywhere between 3.5 to 7 inches long, based on the age and the height of the patient. And we will go into the lower airway here in one sec. Continuing with the upper airway, again, this is kind of the dividing points when we're going into the upper to lower airway. We do have an Adam's apple. That little white kind of bone that you guys see on this picture is the hyoid bone. A lot of things connect to that hyoid bone, specifically your thyroid cartilage. That's what holds your thyroid gland in place. And then we have the cricoid cartilage. Again, that is a very important structure for you guys to know, specifically you guys going into paramedicine, because that is where we're going to actually make a cut for an emergent airway if need be at the paramedic level. The larynx, again, contains your vocal cords, and this also shows the landmarks for something called the Selleck's maneuver, which is something that we're going to train you guys to do in order to help out your paramedics when they are intubating a patient. This is a mnemonic that we actually use called BURP. Stands for backwards, upwards, rightwards pressure. This is something that you guys are going to be doing to manipulate the airway for your medic while they're trying to drop an ET tube. You're going to go backwards, upwards, and rightwards in order to try to get the actual vocal cords in sight of the paramedic, so that the paramedic can advance an ET tube through the vocal cords in order to establish an emergent airway for our patients. Okay, so going down into the lower airway, we remember this is everything below the level of the vocal cords. Once you guys get past the vocal cords, right after the vocal cords is the actual opening to the trachea. Trachea, again, is known as the windpipe. It's about 3.5 to 7 inches long, depending on if you're male or female, depending on your age and your height. The trachea branches off, as you guys can see, into the right and left main stem bronchi. The part where it branches off is known as the carina, C-A-R-I-N-A. The carina actually helps us to stimulate a cough reflex in order to get any irritants that might have passed the nasal pharynx. It's kind of the last resort to stop those irritants before they actually go into our lungs. The trachea breaks down to the right and left bronchi. As the trachea extends into the lungs, that bronchi gets smaller and smaller and smaller. That's when it starts to get smaller. It's known as the bronchioles, or the bronchial tube, and then it goes into the microscopic bronchioles, which is at the very end of that where the alveoli are attached, where gas exchange actually occurs. Also remember, your right lung is bigger than your left lung. You have 3 lobes in the right lung, 2 lobes in the left lung, for a total of 5 lobes total for both lungs. And again, the left lung only has 2 lobes because we had to make room for our heart during our evolutionary period. Okay, so at the very end of the bronchioles, remember this is all microscopic, guys, okay, are your alveoli. The alveoli is where the actual gas exchange, also known as respiration, occurs, okay? It's number 2 of the Fick principle, remember, all right? So the alveoli themselves actually expand and contract when you guys are breathing in. And due to them expanding, it actually creates more surface area for adequate gas exchange. The air in the alveoli must be able to do this, expand and contract, in order for the air to actually reach the alveolar membrane. Those alveoli are surrounded, basically encapsulated, with a whole bunch of capillaries, as you guys can kind of see on this slide here. Okay, the capillaries are in contact, and they must be in contact with the alveoli, because those are the capillaries that are going to be removing the CO2 and unloading the oxygen in order for it to get circulated back to our heart, in order for our heart to be able to perfuse the rest of the cells in our body, to allow the oxygen to cross over for adequate gas exchange and for energy for all of our cells in our bodies. Okay, so going into the Fick principles, once again, this is extremely important that you guys need to be able to get a grasp of this concepts, okay? This is life as we know it, and the best way that we can define it on a physiological standpoint, okay? Air must get into the lungs, also known as ventilation, the mechanical movement of air in and out of the lungs. That oxygen must be crossed over into the alveolar membrane, or gas exchange, also known as respiration. Oxygen must be circulated to the cells, so we have to have a good pump, i.e. the heart, in order for us to be able to circulate all that oxygen-rich red blood cells to perform gas exchange at the cellular level, so that all of our cells can get oxygen in order to produce energy for us. And then that oxygen must be able to get in the cells, what's also known as perfusion, which means that we have to have an adequate amount of pressure in our system in order to help with the diffusion of oxygen and CO2 all the way down to all my cells down into my big toe. All right, so once again, Fick principle number 1 deals with ventilation. And once again, ventilation is just the mechanical movement of air in and out of the lungs. I breathe in, I breathe out. Remember that inspiration is an active process. Inspiration requires energy in order for us to flex our diaphragm. Our diaphragm pushes all of our abdominal organs and contents down in order for our lungs to be able to expand in our intrathoracic cavity. In order for us to get that nice big expansion, get the appropriate amount of tidal volume into our patients, in order to maintain pressure gradients, to be able to diffuse oxygen and CO2, we unload oxygen into our cells, we offload CO2 out of our cells in order for us to blow out the CO2 and get good, adequate gas exchange at the cellular level. Okay, so when we're talking about inspiration, again, it is an active process. The active process means that it requires energy in order for us to perform. the diaphragm and all the accessory muscles contract. Again, your accessory muscles are your abdominal muscles, your intercostal muscles. If you are very short of breath, it could possibly be your neck muscles as well. When we do that, we actually increase the volume in our thoracic cavity. Our negative pressure actually pulls air into the lungs just like a vacuum. Because we're getting that air filling up into our lung pressure starts to decrease, and then air will keep entering the actual chest cavity until the pressure is equal, at which point we are going to start beginning the process of exhalation. Okay, so we have taken that nice deep breath in. We have equalized the pressure in our inner thoracic cavity with the negative pressure drawing the air in just like a vacuum in order for our lungs to inflate. Once our lungs inflates, we have stretch receptors along with chemoreceptors found in our medulla and pons, kind of taking the readings of the CO2 and oxygen level. We have that good adequate gas exchange going on, and now it's time to blow off all that bad stuff known as CO2. All right, so expiration or exhalation, however you want to say it, this is a passive process. It doesn't really take much energy at all. And we call it passive compared to active as inspiration. Inspiration takes a lot of energy. Exhalation still takes a little bit of energy, but not as much as inhalation does. Okay, so this is where the diaphragm and all the accessory muscles relax. We kind of use gravity to help us out with this as well. That diaphragm kind of helps push on the lungs to help them deflate. We have decreased our thoracic volume, and then the positive pressure lets the air out of our lungs, and then we start to reset, going back into that negative pressure situation in our inner thoracic cavity in order for us to inhale all over again. When we're talking about somebody that is experiencing dyspnea, all dyspnea means is shortness of breath. Okay, shortness of breath, the true definition of that is feeling hunger for air or air hunger. Remember that us as normal, healthy adults, we do not breathe to get oxygen. We breathe in order to blow off CO2. We are coming into the realm where we're going to start talking about disease processes where people are no longer breathing to blow off CO2, but now they're breathing in order to receive oxygen. Okay, and we're going to talk about that here a little bit more in a sec. But I want you guys to take a look at this picture. Okay, what do you notice about this gentleman? Okay, I'm going to give you a little bit, just look at it. I want you to kind of really look at this and see what you guys notice. Okay, the first thing that you guys should notice is that this guy is scared. Okay, this guy is very anxious. Okay, he is starving for oxygen. He's also very emancipated. He's skinny. He's, there's not much fat on him. You can see the accessory muscle use specifically in the neck. All right, he's leaning forward, so he's kind of in what we call the tripod position. We're going to talk about that here in a sec. This guy is having a hard time breathing. Okay, this is what your patients are going to look like. We have a lot of these patients out here, and remember, when we're dealing with a respiratory emergency, and I've said this before, but I'll say it again. When we're dealing with a respiratory emergency, these people are already been diagnosed with some form of respiratory illness. Okay, so they already have tools at their house to help them. They already have medications. They might have oxygen at their house. They might have different tools to deliver that oxygen to them. And they will not call 911 until they have exhausted everything they can possibly do at their own homes. What does that mean for us? That means for us in EMS is that usually whenever we're dealing with some sort of respiratory call, we are already behind the 8 ball. Okay? As soon as we get on scene, we need to start playing catch up. Okay? This guy in this picture, he is very anxious. He is very worried. He is very air hungry, and I guarantee he is getting tired of breathing. And when you have somebody come up to you and they tell you, man, I am just getting tired of breathing, that is not a good sign. We need to get them on oxygen. We might need to put this guy on a CPAP in order to help set those lungs open, in order to help for that gas exchange. But we're going to talk about that here in a little bit. Okay. Any kind of obstruction to outflow of the air creates the need to exhale forcefully, right? So when we are seeing forced exhalation, we're seeing signs of respiratory distress, okay? Certain causes of dyspnea, we don't have enough oxygen in our lungs, so we're not getting that good full chest expansion. We're not getting the tidal volume that our patient needs. We don't have enough oxygen in our blood, right? Or we're going into a hypoxemia, right? That's what that means, hypoxemia. There's low oxygen concentrations in our blood. Or we're not actually getting the oxygen to our cells in order to produce the energy that we need in order to keep up with our body's demand. When we're talking about gas exchange, remember that gas, through the process of diffusion, moves from areas of high concentration to low concentration. So when we breathe in, right, our lungs are filled with oxygen, which is much higher concentration than the capillaries that are filling or that are encapsulating our alveoli. Those capillaries have a bunch of CO2 in them. So the oxygen and CO2 will intermingle with each other until that pressure gradient is equal, in which case we will blow out the CO2 and process the oxygen that we have unloaded into our system in order to feed our cells for energy. Okay? So the high oxygen content in our alveoli diffuses into our pulmonary capillaries, and then CO2 comes out of our pulmonary capillaries and diffuses into the alveoli in order for us to breathe that out. Okay, we've touched on lung volumes already. I did skip ahead a slide, guys. Your total lung capacity is right around 5,800 mLs or 5,800 cc's. That's right around 6 liters of actual gas that we can hold in our lungs. Vital capacity is about 4,800 mL, so right under 5 liters. Vital capacity is the amount of air that we actually need to get into our lungs in order to help perform and create those pressure gradients in order to perform respiration or adequate gas exchange. And then we do have some residual volume, which is right around 1,000 mLs, which is 1 liter, which kind of is just there to kind of stent everything open for us before we take our next breath. When we're talking about ventilation volumes, our tidal volume right around 500 mLs for the average adult. 150 mLs remain above the alveoli, known as dead space. Again, that is there to that dead space is actually not involved in any gas exchange, but it's there to keep our respiratory tract humidified, filtered, so when we do take that next deep breath in, it's not such a shock to our system, specifically if we're like in a very cold environment. It won't shut down our respiratory tract. Out of that 500 mLs, when we see that tidal volume, about 350 cc's of that is actually available for gas exchange. Okay. So remember, we can see tidal volume on our patients when we're seeing equal bilateral chest rise. Okay. This is going to become important when we're talking about BVM, and we've already talked about it a little bit. Is that when we're squeezing that bag, when we're holding that mask to the patient's face and we're gently squeezing that bag, all we want to see is good, adequate chest rise. If we see that good, adequate chest rise, we know we are getting the appropriate tidal volume to our patient. Minute volume is the amount of air that enters our lungs within 1 minute. If you guys don't need to know this formula, this is just straight kind of definition stuff for you guys. But basically, in order to get minute volume, it's going to be your tidal volume times your ventilatory rate, which is going to give you your minute volume. Okay. Some more review. Remember that your ventilatory control centers are found in your medulla, and your pons actually has some stuff to do with this as well. It responds to changes in your pH, your acid-base balance, right? It also detects your levels of CO2, whether we have to raise your ventilatory rate or lower your ventilatory rate. We could be blowing off too much CO2, or we may be retaining too much CO2. We're going to talk about that here in a minute as well. And it also kind of focuses on our blood pressure as well. And we'll talk about more about that when we get into cardiac emergencies. Our primary reason to breathe in our healthy adults, okay? The primary reason why we breathe is because we are getting rises in our CO2. We want to blow off that CO2. We are not breathing to get oxygen. We are breathing to blow off CO2. Okay? When our CO2 level rises, our ventilatory rate is going to rise in order to get rid of the excess CO2. Okay? Remember that your ventilatory rate will always follow your CO2. So if your CO2 is rising in your body, your ventilatory rate's going to go up in order to blow all that off. If your CO2 is dropping, okay, your ventilatory rate's going to drop so that we can start building up CO2 in order to maintain normal levels for our body. So how do we as EMTs actually see this in the patient, right? Well, we use something called capnography, or what is also known as end-tidal CO2. End-tidal CO2, in my opinion, is by far the greatest gift that has been given to EMS since the dawn of our existence. This is almost a up-to-date, real-time view of a patient's acid-base balance. Okay, this is a tool that we're going to talk more about during this lecture. There's some great videos for you guys to watch, which I'm going to send you links to via email, and I believe some of these videos are already online in your lab shell for you guys to check this out. Okay. Basically, when we're getting end-tidal readings, we want readings anywhere between 35 and 45 millimeters of mercury. No, centimeters of water. Wow, I gotta look that up. Completely forgot. Just drew a brain fart, guys. I'm sorry. I'll get back to you on that. But this is basically a guide for ventilation for us in the field. Okay. So, a couple questions based on that last slide, and remember that respiratory rates will always follow CO2 levels. Okay. So if your capnography reveals that you have a high CO2 in your patient, and let's say you're ventilating for this patient, what do you guys think that you need to do in order to get those CO2 levels back to normal? Well, hopefully you guys said that if your CO2 is rising, you guys should raise or breathe a little faster for your patient when you're bagging for your patient. Okay, that way we could try to equalize the CO2. If your CO2 is low, okay, we need to slow down our respiratory rate in order to help the body actually maintain or retain some of the CO2, because we may be blowing it off too quick based on that unresponsive patient that we happen to be bagging with the BVM. Okay, so your normal respiratory rate patterns, again, I'm only holding you guys to adults. All right, but I want you to kind of see the difference between different age groups, okay? Adults are 12 to 20 breaths per minute. Children could be anywhere between 15 and 30. Infants are between 25 and 35. Anytime that our respiratory rates are low, so we're just going to talk about adults here. If our respiratory rate is lower than 12 breaths per minute, it's known as bradypnea, okay? This is definitely going to result in some kind of hypoxia for our patients. If we are breathing faster than 20 breaths per minute, we are becoming tachypnea or tachypnic. You might hear me refer to later on in this lecture. And this is usually a result of hyperventilation. We're going to talk about both of these a little bit more as we go through these slides in this lecture.